heroin. She is currently sexually active and I believe a bit promiscuous. We've treated several STDs. She refuses birth control. She says she does not like the way it makes her feel and she doesn't want birth control. So I'm a little concerned about that. I think she lives with her mother and she has a good support system at home. And she reports that nobody else in the home uses drugs. It's just her. But she's really hard to get a hold of. So I'm hesitant about this patient. So as far as her medications, I don't see anything that could be a problem with any of the treatment medicine possibilities. She was previously treated not long ago in 2019, and then very quickly after she finished treatment, she was re-exposed. I think she didn't go back to them to finish her, like the SBR12, she didn't go back to do that. But then when I, got her back in, she was positive again. She is immune to Hep A and to B. Her labs, let me look down through her liver enzymes, looks like they were normal. Her platelets were normal. There's nothing really that stands out on her CBC that looks bad. Her MELD score was only 6, and she's a class A, the Child-Turco-Pugh class. Ferritin 93, negative for HIV. She's genotype 1A. I'm not sure what genotype she was before. I don't have that information. And her viral load looks like it's 240,000. And she's a F0 for the fibrosis biomarker. So on her, I'm kind of on the fence. I don't know. I wanted recommendations whether or not you all think that I should go ahead and treat her because she is actively using, because she refuses birth control. I mean, I feel like treating her would be a good thing because then we're preventing other people from being exposed. However, is it going to do much good? So I needed some guidance on this one for sure.
Thank you so much. Does anybody have any questions regarding the case?
I know you mentioned that she doesn't want birth control. Is she at all seeing a gynecologist?
No.
Is she open to seeing one, even not for like birth control pills, but perhaps a more comprehensive appointment regarding any of that?
Like what kind of comprehensive appointment do you want me to have her see at a GI that's, that we couldn't do in the office? Like what do you mean?
Like, so for like gynecology, I'm just thinking a lot of people will go, oh, I don't want to be on a pill because of weight gain, because of whatever. But there are like lots of different options that not every patient realizes might be available to them.
Yeah, I've gone
gotcha.
through every birth control pill that there possibly is with her, every birth control option. Next one,
I gotcha.
She's just not interested in birth control. She says she, in the past it's made her gain weight and
I gotcha. I wasn't clear. I thought you meant that she was just against the pills, and I was like, we'll have her talk to somebody. She could see all the options. I gotcha. Thank you. Appreciate it.
That's an impressive patient. Wow.
Kaylee,
you want to tackle that one? I think you're into opinion-based approach here, but I don't think you can treat this lady.
Well, yeah, Robin, I actually, what I would ask you first is if she's, is she on HIV PrEP? But I would probably push for that more right now than the Hep C treatment, just because seems like she's engaged in a lot of risky behavior. From a Hep C standpoint, purely, if she's really only smoking at this point, she's not going to be at risk for Hep C reinfection. However, she's already been treated once before and somehow got re-exposed. So you're going to have a pretty difficult time getting treatment approved a second time. With those patients, if I've had somebody that, two scenarios, she could have gotten reinfected. She could have also been one of those few that relapsed or just had a treatment failure. because she's not cirrhotic and Epclusa works very well. I mean, I'd err more on the side of it probably is a reinfection. You just can't really tell. And so I think even if you were in the place where you could treat her now, you'd probably have to go ahead and just treat her as a failure, since you don't have that data of SVR12, which would mean either Vosevi for 12 weeks or Mavorite for 16 weeks. Now, aside from that, in my patients that I'm retreating for whatever reason, whether it be relapsing infection or a reinfection, I usually try to follow them regularly for at least a year before offering treatment again, just because we just have such difficulty. You'll have to have like a full plan in place. Like my patients that I'm retreating, I follow them, whether it be by phone or in office, but every week for the first month of treatment, and then like every 2 weeks and every month for SVR12, because you really have to keep them in care. Now in her case, yeah, I mean, she just doesn't seem reliable enough that she's already gone through treatment once, that I think she'd be in a place that she's ready for treatment again. I definitely understand trying to avoid forward transmission, but if she's truly only smoking, then she wouldn't necessarily be at risk for Hep C reinfection. The other complications are she's also got some meds on her list that have drug interactions with those two options. So the omeprazole and then also the carbamazepine. Rachel may have, I'm not as familiar if the ziprasidone does. I have to look that one up, but I at least know that those two would interact with either of the Vosevi or the carbamazepine with the Mavorite. But yeah, she's complex, and I think we're going to start seeing more cases like this since we're treating more patients now. We're going to be in these situations where we do have patients that have relapsed and that we have to address retreatment, and it is kind of opinion based. It's I guess it's whatever your feel is.
Well, I mean, she's kind of begged for treatment, and I've been hesitant since the get-go with her. She's kind of hard to track down. We usually have to leave a message with her mother, and then we've got what we call our free table here. We put clothes on the free table all the time, and so sometimes she rolls in here to look through our free table, and I'll catch her that way. But she is very, unreliable, and so
what's her motivation for getting retreated? Like, what is there something behind like that's making her really want to have this as a priority for her?
I mean, I can't pinpoint any particular thing.
Okay.
She comes in. I mean, I always feel like when she comes in that she's high on something. And I don't know, she just seems very, very, very sweet and kind, and she just really, really wants treatment, and she wants to be better, and she wants to be healthy, yet she's living this lifestyle that is not healthy. And so she's actually very challenging.
Sure. No, she definitely sounds like she would be challenging. I mean, one approach could be, you could kind of just say, if you can show me that you're willing to follow with me regularly for X amount of time, then we can consider retreatment. But I mean, truly, it's going to be her substance use that's going to put her at risk for complications far quicker than it is the Hep C. But I would actually talk with her about PrEP.
Okay.
About HIV PrEP.
Okay. I will do that. All right. So that one, I'm just going to I'm going to wait till she comes back in the office, and then we'll sit down and have a heart-to-heart, and we'll really discuss options. And then maybe I could bring her in every week, and as long as she's compliant for, I would say maybe 6 weeks, if she comes to every week appointment, then maybe I'll talk about it further with her. And then if so, then I could do, you said Mavorite for 16 weeks would be appropriate for her if we stop the omeprazole, and I guess I did the carbamazepine.
Well, Yeah, the carbamazepine would be the big one with the Mavorite. The omeprazole, not so much with the Mavorite. But it would be 16 weeks, and I believe that's the preferred with Medicaid for retreatment. One thing is too, you may want to print out. I've done this with patients too. That for Medicaid, there's a retreatment supplement. So it's like a prior auth form, but it's actually a retreatment supplement, and there's oh, I wish I had. We can send it out. Or maybe Rachel can pull it up too, but or Angie, but it's basically saying, you know, what caused treatment failure the first time, what's going to make it different this time, like what strategies do you have in place so that this time it's going to be successful. And so Rachel just sent it to everybody, but I like to actually have that form with me in clinic when I'm discussing retreatment. That way the patient can also go through and we're developing the strategies together. So I'd probably do her 6 weeks, like you said, weekly for 6 weeks, and then also print off that retreatment supplement and really go through each of those questions so you guys have a plan in place. Maybe even have her sign it too.
Okay, all right, I'll do that. I appreciate your all's
And then,
input.
Robin, did you talk to her about the fact that we don't know if these are safe if she gets pregnant?
I did talk to her about that, and that was another thing that I don't know what to do, because she is actively having sex. I've treated STDs a couple of different times with her, and I just can't make her understand the importance of not getting pregnant. I mean, I just kind of pray every night that she doesn't. She definitely does not need to have a baby at this point, but I don't know what to do about that. If they refuse birth control, I mean, do we just refuse treatment, or? I mean, do you have a suggestion about that? Should that be a stipulation that I say no, absolutely no treatment unless we have some type of birth control in place?
Yeah, I think so.
And yeah, that
So
would
you-
probably be my approach too. I mean, there's really limited data. I think the main one is with Harvoni, that it was just a really small group, and it wasn't shown to have any effect on the fetus. But since we don't have that data, I just tell her, you know, you can't responsibly offer treatment if she's not willing to avoid pregnancy.
I think for her too, it might be inappropriate. I don't know. I might require her to have either an Nexplanon or an IUD, because I know she's not going to be compliant with the birth control pill. If that ever happens, you know, I can prescribe it, but that doesn't mean she's going to take it. So, I mean, I guess I could require that as a provider, that she'd have to have that before I could proceed with treatment. Do you all think that would be reasonable?
I think that would be appropriate. I do. I think
100%.
you know, really going through and saying these are the requirements that I'm going to ask of you before we're going to consider retreatment.
Okay.
And
Yeah,
there
like-
is verbiage on the Medicaid patient provider agreement that says, you know, they were counseled on the importance of 2 forms of birth control, including a barrier method. So that could be additional ammunition there.
Okay. All right. I appreciate all the input, guys.
Yes. Robin, I love Kaylee's question, you know, of like trying to figure out why she really is. I mean, she's in a ton of like self-destructive behavior, but she has like this desire to get rid of her hepatitis. I'm just curious why. And try to really pin her down on that one out of curiosity, and,
Okay.
and teach us, you know, if she's hurting, if she's tired, if she's or if that's her scarlet C that she's just trying to erase from her life. Yeah.
Could be it. Yeah, her personality and her actions do not mix at all. It's just, she's an odd case. But I'll try to get to the bottom of it and see if I can see how motivated she actually is, and maybe at some point I can update everybody on what happened with her.
Does she have a therapist?
I don't think so. We have, you know, I work in the facility I work in is a mental facility as well. And usually we get patients into there. She'd been in a Suboxone program, I think, at one point. Is she still in Suboxone? I don't think so. Oh, yeah. Well, she's got Suboxone on her list. So somewhere, I can't remember if she comes here or not. I'm sorry, there's a lot of them, but she is getting a Suboxone from somewhere, and usually they do some type of counseling with them in those programs. Yeah, they have to. So
Yeah.
I'm not sure how compliant she is with that either. I don't know.
I mean, she's actively taking Suboxone. She'd have to show to group. But she might, I mean, when you talk with her, if you kind of have this heart to heart and find out that she's, you know, having all these self-destructive behaviors because of something that's going on, she might take better to the idea of exploring the birth control options later if she is able to talk with you first about like setting up some sort of therapy prior to going down this road. Because if the birth control feels like a big no-no to her, then I mean, clearly we've identified there's something else going on. So she might take better to kind of an in-between step, kind of added into there before it becomes a you have to do all these things. Otherwise you can't get treatment for this big illness that is affecting you.
Thank you so much. Absolutely. And Julene echoed that mental health does help. That's great. Thank you so much for your guys' input, everyone. All right, are you ready for the next case?
Okay. Well, I'm gonna turn my computer, let Bree, we're in the same room.
Oh, that's okay.
I don't know why mine's not echoing and hers is, so we're gonna switch in just a second, okay? Just leave
No
yours with
worries.
me.
Thank you so much.
Turn this around.
Okay, can y'all hear me now? I'm not echoing.
No, you're good now.
Okay. Where's the screen
Oh, it's probably over here. And her screen. We make this.
at? Okay, hold on, guys.
No worries at all.
Okay, stop moving around, sorry. Okay, there you go.
I have mine.
Oh, yes. There you go.
Okay.
You just started here.
Okay, this is a 66-year-old female. She is a current pack-per-day smoker. She does deny drug and alcohol use, but she claims that her ex-husband was Hep C positive. She's never admitted drug use to us. She has a pretty good home environment. Comorbidities, anxiety, arthritis, COPD, hypertension, hypothyroid, GERD, PVD, and thrombocytopenia. Her meds looked okay to me. She is vitamin D deficient, but we're supplementing that right now for her. The omeprazole 40, we were thinking Maverick, so we were going to decrease that to 20 if that's something that y'all agreed with. And let's see, her statin as well. Her cholesterol panel, the recent cholesterol panel she had was good, so we were going to pause that for her treatment if that's something that you guys are agreeable to. Her blood work was good. Her platelets, they were a little.
They had started out of the 120s, they come up some.
Platelets, yeah, her platelets have came up from her last blood draw that we did. Her MELD score is a 6. Child Turco Pew, she's class A. Her APRI score 0.355. Basically with her, this was a requirement for her insurance was to consult with you guys. So I didn't have any particular questions. I felt like she was a good candidate for Maverick for the 8-week round. So just getting your all's input to see what you guys think.
Thank you very much. Go ahead, Caleb. John.
Oh, I missed how old she was, and I'm on a mobile, so I couldn't read it. I
66.
apologize.
She's
56.
66.
60. Okay.
Has she was this a new diagnosis?
Yes.
This was, yes.
Okay. Do you know, I mean, has she had any blood transfusions or like any other risk factors besides besides considering substance use like tattoos or air gun immunizations or
No, nothing
anything in
that
the
we're
past?
aware of.
We feel like she probably has had some drug use. She just didn't want to admit to it.
Sure.
Just
sure.
because we know some people that know her and, so I
Sure.
feel like there was drug use, but she's kind of ashamed and she doesn't want to admit it right now.
Sure. Do you have any liver imaging on her, like an ultrasound?
We have an ultrasound ordered.
Okay.
That's going to be coming up in January. That was the earliest we could get her scheduled.
Gotcha. Okay. I mean, she doesn't have transaminitis, but just because she's 66 and if she's had this virus for a long time, even though her fiber test is F2, I just like to, sometimes the ultrasound will show a lot more pessimistic reading and may have advanced fibrosis. So I'd probably just double check based on that to make sure she doesn't have some underlying cirrhosis, or at least advanced fibrosis. So actually, I'd prefer Rachel to give her input on the med interactions, because I think I agree holding the statin would be the best option for her if you're doing Mavorite. The omeprazole, you would not need to actually adjust that. It won't have any interaction, but the primidone, I believe, has a potential interaction as well. So I think, Rachel, do you have input on her med list?
Yeah, you got the main ones here with the omeprazole and the lovastatin. So the omeprazole is not going to interact. She could hold the lovastatin. The primidone is going to have the same interaction, theoretical interaction as the carbamazepine in the last case. So a couple of things on those kind of anticonvulsant kind of medications. That category is in a group of enzyme inducers. So what that does is chew up essentially or metabolize more quickly the direct acting antivirals, and it's across the board. It doesn't matter which one that you use, whether it's Mavorite, Epclusa, Harvoni, Zepatier. They all, in their package insert, they do say specifically it's not recommended to give them concomitantly. So from that standpoint, it's not recommended. So the main issue from there is going to be, what she's using the primidone for, who's prescribing it, and if they would be willing to transition her to another agent that doesn't have that interaction. Now, there are some studies that have looked at some of these drugs. I don't think primidone was included. Most of the studies have, and they've been very small, like 5-7 patients, have looked at primarily oxcarbazepine and carbamazepine. So they've found that patients have been successfully treated, but they, were in a study, they were watching those patients closely, making sure that they were adherent and had no other drug interaction. So the majority of those patients did really well and were cured. So I think we're going to get more information about these agents as more and more people are using them in the real world where patients cannot come off of these drugs. They can't change to something, or they're unwilling because they're stable and they've tried other things. But right now, like I said, in the package insert, it does say that it's not recommended because the risk is that there's not going to be a high enough concentration of the Hep C medication and they could potentially fail treatment.
Okay.
I know it's not good news, but hopefully helpful information.
Any other questions or comments for this case?
Just mechanism of thrombocytopenia in Hep C can be interesting and confusing. And I didn't know if it was elucidated in, by the way, I couldn't spell that word. I have no idea how to spell that word, but I can barely say it. But it can be autoimmune, or it can be sequestration. It can be kind of a result of cirrhosis and big spleen, etc. Or it can literally be part of the autoantibody milieu of extrahepatic manifestations. Teasing that apart probably doesn't matter when you have a platelet count of 140. But if you ever had somebody with a, kind of significantly low platelets, it can matter, because therapeutically you can help the autoimmune mediated version, whereas you can't really help the cirrhotic version other than treating the Hep C. Actually, you treat them both the same way, but sometimes you supplement with prednisone if it's ITP or IVIG or something like that. But purely interesting, not really pertinent for this case, but platelets and chronic liver disease is always fascinating.
Excellent. Thank you so much, Dr. Gilfus. And thank you guys for your cases. Any other questions, Brianna or Robin?
No, I think we're good. Thank you, guys.
Oh, thank you so much. Of course. All right, Angie, I made you a co-host, I believe, going to now. So whenever you're ready, you can go ahead and begin.
Alrighty. Let me just get situated here. Swap our display. And here we go. You guys can all see?
Looks great.
All right. So my name's Angie Wochuk. I'm director of Rational Drug Therapy Program, and I'm also a service assistant professor with the WVU School of Pharmacy. I was trying to rack my brain for a topic, and there were some updates with the over the year from the guidelines, and so I thought some of them were kind of a big deal. So I thought we could discuss those. And in the future, if you guys have any medication related topics, please feel free to let everybody know, and I'm happy to present on anything you guys want to hear about. But I think that this is kind of interesting that we'll talk about today. The main thing that they updated in the guidelines in the last year was that there's a new medication out, and it's a new in-class medication. So it's lenacapavir. And one thing to note about the way it's spelled, so if you're like me and you remember generic medications and put them in a class by the way they're spelled, so I always want to say lenacapavir because meds that end in pravir are the integrase strand transfer inhibitors. So this is actually not in that class. That's why it's lenacapavir. It was approved in December of 2022, brand new class of medications called capsid inhibitors. It does have to be used with other medications. Otherwise, you can have some resistance issues because it's not quite effective enough to be used by itself. And there's right now nothing else that's long acting enough to pair with it to make it a viable regimen that could be used standalone. So you do have to take it with oral options. But it's good because in a couple of years, maybe that'll be a different case. And how wonderful would it be if we could just give folks a twice a year injection and they can forget about their HIV for the most part and don't need to be reminded with daily administration of medications. For right now, this is approved for use in heavily treatment-experienced adults with multi-drug resistant HIV-1 infection. So HIV-1 is 99% of the infections in the United States. So this is for approved in treatment for that population. It's not approved yet in adolescents or the pediatric population. So this is just for adults. There's no current resistance test that's you can order for it, but that's not unique to this medication. So imbalizumab, which is a CD4 lymphocyte post-attachment inhibitor, that does not have a resistance test, and neither does fostemsavir, which is the GP120 attachment inhibitor. So it's not unique to this medication, and it is fairly new. It does have to be, at this time at least, administered by a healthcare professional. One other good thing about this is that this is a sub-Q injection instead of being an IM injection. So maybe someday we'll see where it can be self-administered by a patient, but for right now, they have to come in and get it in clinic. If you've been following this med at all, it was put on hold briefly during its clinical trials, and that was just due to some compatibility issues with the vials. It was made of a type of glass called boryl salicylate, and when the medication was combined with it, they had particles forming in the glass. So they just had a switch to a different type of glass, and it fixed the problem. So they took that off of hold in May of 2022, and then the med came to market in December of 2022. So since this is a new class of medications, I'll speak a little bit to the mechanism of action. This is an inhibitor of the HIV capsid protein, and a capsid protein is just basically the protein coat surrounding the RNA of the HIV virus, so the package of the genetic material for the virus. And what happens during replication is the capsid or the package is basically stripped away, releasing the HIV genetic material into the cell of the nucleus. And it works in a couple different places in the viral replication process. So it targets that same binding site, which functions to help the HIV DNA enter the nucleus of the host cell. It also interferes with functioning of polyproteins, which assemble and incorporate the viral glycoproteins, and this reduces the capsule protein production. So it inhibits the production of a new viron, essentially. And then it also increases the rate of HIV capsid assembly, resulting in abnormalities in the capsid structure, and therefore blocks the release of the new virons. So we'll speak a little bit about the half-life of the medication. So Selenca is our brand name for this medication. It comes in tablet and injectable formulations. The tablets are really only going to use for the lead-in for this. And for this medication, they do recommend a lead-in. If you remember, another injectable option that we have, Cabenuva, does have a lead-in, but the guidelines have sort of said you can forego the lead-in for that medication. For this one, they do, at least at this time, recommend that you lead in with capsules. And then the injection sub-Q twice a year is going to be your maintenance phase. The half-life of the PO formulation is 8 to 10 days, or I'm sorry, 10 to 12 days, and the sub-Q formulation is 8 to 12 weeks. So that's something to consider. It's wonderful that we only have to administer it twice a year, but we need to keep that in mind when we're thinking about drug interactions and, patient med list. They might forget to put this on a med list, and it does have some drug-drug interactions, and it can even have some drug-drug interactions after it stops. So the long half-life is something to consider there. These are the initiation options for the lead-in dosing. There are two, so there's option 1 and option 2. Obviously, option 1 is less complicated, but I list option 2 for completeness sake because it was used in the studies, and it is effective to do either one. You get to steady state in the same amount of time according to the data that we have. So either are a viable option. The maintenance phase, so you have the injection. So you need to do 2 1.5 milliliter injections to make up the full dose. And again, you do that every 6 months. You have 1 to 2 weeks wiggle room for the injection day. But if they do go to 28 weeks or 196 days post their previous injection due date, they have to restart the lead-in dosages to continue on. For adverse effects, this was pretty well tolerated overall. The main thing that was an issue were injection site reactions. They were frequent, but usually not severe, and they didn't very frequently lead to someone stopping the medication. Nodules can form, and that might be something to counsel on just so the patient has a heads up, but it was overall pretty well tolerated. Nausea, diarrhea, and headache are just sort of the catch-all side effects that are associated with most drugs. They didn't seem to be super problematic that we would think that they would be an issue with patients taking this medication. And as far as administration of this, so I did mention the nodules and counseling on that. They can develop and they do tend to persist. Rotating the injection sites does help, so recommending they rotate them and making them roughly 2 inches apart are good counseling points. Now, the healthcare provider is the one injecting, so it's just something to keep in mind, but then counseling them that, here's where we injected, you might notice a nodule, it might stay for a little while, that's normal. Going back to the discussion about drug interactions, so lenacapavir is a moderate CYP3A4 inhibitor, so it can have the potential to increase concentrations of other meds. But then it also, the lenacapavir levels can be significantly reduced in the presence of strong CYP3A4 inducers. So we want to keep that in mind. Strong CYP inducers that you want to stay away from with this medication, so rifampin, carbamazepine, phenytoin, kind of are problematic anti-epileptic medications. St. John's wort also can interact and can be bought over the counter, so that's something to keep in mind. And those are going to decrease the levels of lenacapavir. Some cautionary things to keep in mind with other medications. So efavirenz, atazanavir, cobicistat, their recommendation is to not co-administer on that list because they can have an interaction as well. Now, some things that I did not include on this list that are very commonly used medications that are something to keep in mind that aren't necessarily a direct recommendation to not co-administer would include digoxin, lovastatin, simvastatin, oxycodone, tramadol, buprenorphine. Lenacapavir can increase the levels of these meds because it has that ability to inhibit the CYP system. So again, not a direct contraindication, and it's not a terribly strong interaction, but it's something to keep in mind because we might want to look out for side effects and toxicities particularly with buprenorphine. So when we're treating patients for MAT, it might be something to consider if you're debating on whether or not to start an injectable buprenorphine product versus an oral. And then, of course, if they're on tramadol or oxycodone, slowly titrating those products if they're also concurrently using this medication is something to think about. And from a drug interaction standpoint, so we need to keep this medication in mind even after it's discontinued, because the guidelines recommend that up to 9 months you can see drug-drug interactions with this, and in some patients even longer. So it's something to counsel patients on to make sure that they do keep it on their med list, even though it's not something in their pill box that they're on, so the providers are aware. And then if you discontinue this medication, think also about the new regimen needs to be started no longer than 28 weeks post the last injection. Clinical pearls with this medication, there's no pregnancy data quite yet, but the animal studies show some promising results, so they don't show harm at this time, but it does not have the indication yet. There's no dosage adjustment for the elderly, and in moderate or mild renal impairment, there's no dosage adjustment. When you get into creatinine clearance less than 15 or a dialysis patient, it's just not been studied, so it's not recommended for use in that patient population. And for liver impairment, as long as it's mild or moderate, there's no dosage adjustments required. But if the patient has Child-Pugh class C, it's not been studied. So again, it's not recommended in that category of patients. The clinical trials, I'll mention them and give an overview of them. I won't do a deep dive into the clinical trials, but if y'all have questions, feel free to ask. The Capella trial was the first main trial that evaluated patients very treatment experienced, sponsored by Gilead, which is the maker of the medication. It was a 52-week study, so they didn't enroll a large patient population. There were about 72 for this study, but also they used heavily treatment experienced patients, so that's sort of going to lend to a smaller patient population that you can survey. So the inclusion criteria involved patients who had resistance to at least 2 agents from at least 3 of the 4 most commonly utilized this class of medications. And they also had to have no more than 2 fully active antiretroviral medication options from the 4 main classes. And they switched them into 2 cohorts, one randomized, one non-randomized, and studied them over the course of the 52 weeks. So they had some promising results. So at week 26, 88% of the patients in the randomized cohort had undetectable RNA viral loads, and 83% in the non-randomized cohort. So they had good results from that study. The Calibrate study evaluated patients who were treatment naive. So this is also being studied not just for the heavily treatment experienced patients, but in treatment naive patients as an initial therapy. And it had promising results as well. The goal of that was to compare it to the existing existing treatment regimen that is popularly used. So the bictegravir containing regimen, which is one of the most popular rapid start treatment regimens for most patients, treatment naive, starting HIV therapy who you don't have labs back on yet. So it was a good comparator. And at the 1-year mark, 85% of patients in all 4 treatment groups were undetectable. So they had 4 treatment groups. 1 received the injectable lenacapavir, and they received that with emtricitabine and TAF, which is the tenofovir. Because like I said, you have to take it with an oral. You can't take it standalone. Group 2 took injectable lenacapavir with the emtricitabine and TAF, so same as group 1. But then when they got to the maintenance phase, they only took lenacapavir injection every 6 months and bictegravir daily. The third group took oral lenacapavir with the 2 combining medications, emtricitabine and TAF. And then the 4th group just took the standard regimen of bictegravir, emtricitabine, and TAF. And so 85% of everybody in all 4 of those groups were undetectable by year 1. It's also being studied for use in PrEP. So that's an exciting thing too, because to inject someone twice a year would be a great PrEP treatment option, because we're no longer worried about compliance and things of that nature. Something to think about for that, though, is that instead of like cabotegravir is currently out and for use for PrEP, but this would be an every 6-month option instead of every 2-month injection. So what we would do, we'll have to look at the guidelines and what they recommend, but usually you would get STD and HIV testing every 3 months. So it would be probably bringing the patient back in between injections for those testing. So studies are ongoing. We don't have the data back, and it definitely doesn't have that indication just yet, but they are studying it. I think there are 5 studies, they're called the PURPOSE studies, that they're studying in individual different high-risk patient population groups. So that might be something that we see on the horizon in a couple of years. Other updates not linked to that new medication that came out. So this one is kind of a big thing as well for patients who are taking the cabotegravir injectable for PrEP. There's a new study that shows that there is some integrase strain transfer inhibitor resistance emerging in patients who have been exposed to that when they were using it for PrEP. So the new recommendations state that if they have a history of PrEP in the form of the cabotegravir injectable, then they have to have resistance mutations testing before you would start a regimen. And this is a big change because the regimens that they typically recommended in the guidelines for rapid starts for patients who you have no labs back on yet included primarily, I think 4 of the 5 were integrase strain transfer inhibitor regimens. So this says you should not use those if they've been on cabotegravir for PrEP. And they actually recommend a darunavir, tenofovir, and either lamivudine and tricytidine as initial treatment option for that patient population. So of note, if the patient is treatment naive and did not take cabotegravir for PrEP, you can use an integrase strain transfer inhibitor regimen without testing. So since we touched on rapid start, I just wanted to briefly mention it, even though not a ton of changes in the guidelines happened surrounding that. So the recommendation, as it has been for a couple of years, is to start antiretroviral therapy at their visit that they have the diagnosis. So instead of saying you have HIV, let's get all your baseline labs and let's get your resistance testing and come back in a couple of days or however long it takes to get that back, they're recommending that the patient not leave the option without, or leave the office without a treatment option. And that's for a couple of reasons. They have studies that say that a lot of patients don't come back to initiate treatment. So don't quote me on this statistic, but I think like 20-25% of people don't return after they're diagnosed for their treatment. And then the other advantage to this is that we're going to get them to an undetectable viral load in less time than if we saw them back in a couple days to a week. So there's an advantage there. And this is especially recommended for patients who are homeless or who don't have a good contact information, which can be a patient population as well. You still definitely want to get all the baseline labs. That's not unimportant, but you want to go ahead and send them home with medication that day while you're waiting on those lab results to come back. And you can always pivot if they come back showing kidney dysfunction or liver dysfunction or something to that effect. If you don't have Hep B labs that are current for them, because there's such a concern with them being dual infected, the guidelines recommend that you start a regimen with Hep B activity for that type of patient. Always make an appointment for the return visit. And the one lab you do have to have back, obviously, is the HIV diagnosis. It has to be confirmed before starting any antiretroviral therapy. And the last slide that I have is just a reiteration of the recommendation for rapid start, because that did change slightly. Like I said, I think it was 4 integrase strain transfer inhibitor regimens and 1 2-drug regimen. Well, they've sort of revamped it. And now these are the rapid start recommendations for patients. They say for most treatment naive patients, so meaning if they don't have any glaring comorbidities or things of that nature, this is what you're going to start in most of those patients. And then again, just to point out, the boosted darunavir is going to be your choice for any patient who's had previous exposure to the cabotegravir for PrEP. And for regimens on this recommendation, if it's not otherwise specified, anywhere tenofovir is recommended, and we didn't specify which formulation of tenofovir, you can pick between the two. They're both very efficacious. Usually you will look to things like insurance coverage and access and cost and pick the best one. TDF or tenofovir disoproxil has some associations with kidney dysfunction and osteoporosis. So if you have a patient with some pre-existing affinity to either of those disease states, that would be a reason to pivot to the other formulation. TAF or tenofovir alfenamide can have some association with weight gain and less optimal lipid levels than TDF. Again, if you have a really healthy 26-year-old patient that has no comorbidities or nothing going on with that would be indication of kidney dysfunction, then you can use either. I would just go purely off of coverage, access, and cost for those patients. Do you all have any questions for me? I appreciate your time.
Thank you so much. Go ahead,
Thanks so
Kaylee.
much, Angie. That was great. Very informative.
Thanks, y'all.
Yeah, I don't know if it's really a question, but you'd mentioned that if you're doing rapid start and you don't have Hep B serology back, to go ahead and start them on an agent that also covers Hep B. Do you know, I mean, we just have such high rates of Hep B in West Virginia. I guess my worry would be that when you're doing that and they don't come back for follow-up and they stop their regimen, that then you're inducing flare. I mean, has that been described at all with the rapid starts?
They didn't go into it, but I can definitely see where that would be a concern. They just kind of said if you don't have recent Hep B information for them to start something that does cover that Hep B. But yeah, that I could see where that would be a concern.
Okay. Thank you. But it was, yeah, great. You very, very informative. Thank you so much.
Yeah, thank you all.
Thank you very much. Any other follow-up questions or comments?
I just have to give a pharmacy school, that WV pharmacy, Mary, Mary, the assistant dean and all, they're pretty good coming from a pit girl.
We appreciate it, for sure.
Just want to say that,
Thank you so much for that. All right, we'll get a little bit of time back. The next time we'll see you will be after the new year. That'll be January 11th. You'll get more communication on that, and we're finalizing the curriculum as we speak. So we really appreciate everyone's time. Have a happy holiday and safe one. Thank you.